Welcome to everybody. We're here to have a Worldwide Journal Club discussing the Excite trial with a range of expertise across the panel to also talk about the implementation of constraint-induced movement therapy and the lived experience of somebody who's done constraint-induced movement therapy. So what I'll do first is just ask everybody on the panel to give some words about their background.
Sure. So my name is Lauren Christie. I work as an occupational therapist, clinician researcher, and my postgraduate studies have actually focused on the implementation of constraint-induced movement therapy into public health settings here in Sydney, Australia.
My name's Reem. I'm a physiotherapist. I work in a brain injury rehabilitation unit. I also was a research officer on Lauren's project, so hopefully I'll be able to give some feedback on clinician perspective and translation of the research.
My name's Scott, and I've recently been through a brain injury, and I've done the CIMT course, so I know exactly what it's all about and the things you've got to go through.
My name's Emma. I'm a very newly graduated physio heading into the public health system next year and hoping to learn more about the implementation of CIMT.
My name's Leanne Hassett. I'm a full-time academic at the University of Sydney. I'm a physiotherapist and worked clinically in a brain injury unit for a number of years.
And I'm Simone Dorsch. I'm an academic at the Australian Catholic Uni and I teach with a collaboration called Stroke-Ed. I'm a physio by background.
First of all, in terms of the inclusion criteria, it was that participants had to have a mini-mental of greater than 24. And I was thinking, now that's quite a high score, isn't it? And does that exclude quite a large number of people after stroke?
I guess if I can speak from our clinical experience in terms of applying CIMT within routine practice, that is one of the challenges. I think the important thing to remember with CIMT is that the intervention is structured around overcoming learned non-use, and a big component of that is around the stroke survivor changing their behaviour. And that's really the key reason why this kind of cognitive cutoff score has been set, is around the behaviour change elements of the intervention. Having said that though, in terms of applying it within clinical practice, we've used that number more as a guide, and then considered other elements that might support someone who has slightly more impaired cognition to be able to participate in a CIMT program. So things like if they have good carer support and that person can support them through both attending some of their appointments or with their homework and transfer package at home, could they then still participate actively within a program? And we've actually seen some really good outcomes within that as well. So I think it's using that as a guide and then considering what other supports are available that might assist that person to be able to participate in the program.
Why do you think they included standing balance as part of the?
I think just that risk of falling over, maybe just with having their their non-affected arm. I know they don't completely restrain it, but still having the mitt on, I just wonder if it's just a safety aspect.
Yeah. That's my understanding as to why they did it as well.
I kind of felt when it first started that people did actually used to put slings on, but I mean obviously it wasn't shown in that, but I kind of feel back when I first started using it, that often that was the strategy, was to use actually a sling, and in that case you definitely needed to make sure that they had good standing balance.
So I think clinically we certainly wouldn't exclude someone on the basis of standing balance if their goals were around arm recovery. Their standing ability wouldn't limit their participation in a CIMT program. It's interesting that's what they did in the study.
What about but on for 90% of the day?
So do you want to? Well, if they needed it for safety reasons, for example, if they had to hold on to something to transfer or mobilise, then they would take the mitt off for that part of the day, just whilst they were doing those activities. So for any unsafe activities, they would take the meat off. And that includes other things like maybe drinking a hot cup of tea or coffee, toileting. So that would be the times when they're mid-off times.
And all of that is clearly documented in the person's behavioural contract and their daily schedule before they start their CIMT program, so that that's all mapped out very clearly around what are MIT-on and MIT-off activities for safety.
Is there anything else in the exclusion criteria about language impairments or neglect?
Excluded, so we've got the mini-mental score, physician-determined major medical problems, could interfere with participation, previous stroke, excessive pain in any joint of the paretic extremity, younger than 18 years, insufficient stamina to participate, substantial use of the paretic arm in daily life. No, that's as far as we get.
Can be one of the challenges in relation to the elements of the transfer package, because it does involve a lot of communication with the stroke survivor or person with brain injury around what they've done for homework the night before, recording in their home diary. No, Scott.
Give me nightmares.
Yeah, completing parts of the motor activity log. So that which really then reinforces some of the elements of the behaviour change. So
And part of and also the coaching part of CIMT and understanding the coaching and feedback
during shaping.
during
activities.
shaping.
Because that's massive. The feedback is huge, or was for me anyway.
I must have missed it, but did they actually mention how many participants there were across all 7 sites?
Yes.
Yes, I want to say 220,
I'll
but I
say
think Leanne's
228.
going to double check that. So
my flow
yes, I
diagram.
mean, that's one of the reasons why this was such and exciting.
222,
Trial.
222 were randomised.
Session cohort.
Yeah.
Yes.
Yes.
I think prior to that, a lot of the CIMT studies were single site with quite small sample sizes, so that's another reason why this is fabulous to see.
And was there any difference between the results with people that had the pre-morbid hand dominant side as their affected side?
I looked that up they did look at that in the statistical analysis. They did account for whether the affected hand had previously been a dominant or non-dominant hand, and it didn't make a difference.
Okay.
It didn't seem to have any impact on the outcomes.
Okay.
From what I understand, the trial, it ran over 2 weeks. Is that true?
The intervention.
Yeah. Do you guys think, based on your experience, that that's an adequate time to determine the effect of CIMT in that period of time?
So I think from our clinical experience, in terms of delivering CIMT programs and also for the sites that were involved within our implementation study, usually they were delivering CIMT programs as either a 2 or 3 week program. So this might be a good point for me to mention that following the Excite trial, there's been further studies investigating different models of delivering CIMT, because one of the criticisms of the Excite trial was that it involved up to 6 hours of intensive practice per day, and whether that was clinically feasible in a lot of settings. So following on from that, there's been a further series of other randomised controlled trials that have used different models of delivering CIMT for, say, 2 hours per day or 3 hours per day is now commonly used by the TORB clinic. There's another model that does it just for half an hour, but over a 10-week period. Within our implementation study, though, a 2 or 3 week model was used, and usually people were receiving active upper limb practice for between 2 and 3 hours per day, and we saw clinically important improvements within our cohort that would be consistent with what we would expect from the results that have been published.
Okay.
And sorry, did they mention, I guess, in the paper why they didn't conduct it for patients in that really acute phase? So in that 0 to 3 month phase, where they could have been doing this type of therapy as well?
I think the primary reason outlined within the background of the paper was the concern around, I guess because that's kind of a key window for that spontaneous recovery, that first 3 months. So not wanting that to be a confounder in terms of the outcomes is my understanding.
Yeah, that's my understanding from the background.
Having said that though, there's since been further studies that
Yeah.
have been done looking at CIMT in the more acute phase.
Yeah, for sure.
What are some of the challenges or barriers that you've found clinically in terms of recruiting patients or patient compliance? And then also, Scott, what are some of the challenges that you faced?
The mitt was challenging. We're in the mitt every day and just functioning with the mitt on it, and especially because it was my non-dominant hand was my affected one, so the mitt was on my dominant hand, so all I wanted to do was take it off all the time, but I couldn't, you know what I mean? But I'm strict on myself, so if it's on there for a reason, so once it was on there, it wasn't coming off. So, but like everything, you get in what you put out of it. So.
And are there systems that you used to, like, to recording how long you had the mitt on for and having to report back?
No systems, just, it was on all day, every day. That was it.
Yeah.
Well, I followed the rules, and that's, if I'm cheating, I'm only cheating myself. That's the way I look at it. If I take it off, who am I cheating? You're not affected, Laura's not affected, I'm affected. So.
If we think about what some of the key barriers were to implementing CIMT when we explored that through focus groups, actually the biggest barriers are around therapists' lack of knowledge. Linked with that is lack of skills, and then beliefs about their capabilities. So in terms of their confidence, so because they feel like I don't have a good understanding of this intervention, all the bits that go within it, I don't then feel confident, so I don't offer it to people who would be eligible for it. And that's kind of step one. So if I even take it a step back before we're even considering whether stroke survivors would like this intervention or not, one of the key barriers was they weren't even being offered it as a potential option in terms of their upper limb therapy. So a lot of the implementation strategies that we use within the Active Arm study were focused on therapist behaviour change, increasing their knowledge and skills, and then them developing clear implementation plans around how they could use their existing resources by occupational therapy and physiotherapy working collaboratively so that they were then able to deliver these programs rather than feeling time intensive because it's just down to me as the person's physio. And looking at different models of delivery, so group-based models, in some instances to share the load, so again that it doesn't feel like this intensive thing where only one person is responsible and it takes up a large chunk of the day. In terms of people wanting or being willing to participate in a CIMT program, within our study we did find that there was a discrepancy between once we had improvements in terms of therapists offering the intervention, there was still a gap between those people that were offered it and those people that then received it, so that there was about a 25% difference. At this stage we're not clear around whether that was how the intervention was presented to the person as an option. So how much of it is around how we educate people around the benefits and the evidence supporting its use, or whether it was just around individual preferences. So maybe that wasn't a goal for that person at that time. That there's a lot of, I guess, factors that we think probably come into play. For those people who did agree and then participated in a program, we also conducted follow-up interviews though, and the feedback from that was very positive. So those people who received the intervention could very much see the benefits, talked about how it helped them to return to really important roles within their life, and that they had really good improvements in their arm function overall. And that was interviewing a cohort of around 45 people who'd received CIMT programs.
How did you feel after your programs?
It gave me my life back. That was the way I look at it. I know it sounds like I'm bigging it up, but it was massive because I'm a tradesman. And without my use of my arm, I wouldn't be there. And I drive a manual car. So without the course, I'd be who knows where.
Can you describe the program you did? Like how many hours you had to do? And
2 to 3 hours a day.
Yep.
And I had multiple different physios and stuff, or people helping me, doing the course with me.
Do you want to tell us a little bit more about too how you found the shaping activities, so the different activities where they'd report back to you how you're performing and then how they made them more challenging each day?
Yeah, they made it more challenging, but it was a goal for me to beat myself. And that was a big important thing. So the feedback was really helping me so I could improve every day. When I got the feedback, that was really good. And it was just different things that you wouldn't normally do, if you know what I mean. So doing different things, which was good. It was really good for me. I really enjoyed the course.
Remember what some of them might be?
Picking up coins.
Yeah.
Yep.
The bolts, nuts and bolts. And being a tradesman, it's something I do every day, nuts and bolts. So it was massively meaningful for me.
Yeah. How much movement did you have in your left arm before you started?
Not a lot. I couldn't even pick up a cup of coffee and drink it. Whereas now, I noticed before I did this panel today, I was drinking the coffee with my left hand. And at work today, I used a dustpan and brush, which was not possible before the course. So just stupid little things like that people take for granted, I wouldn't have been able to do.
So when you first started doing the practice,
Yep.
the shaping, you wouldn't have been able to do nuts and bolts at the beginning?
No, not
So
at the beginning.
What sort of things did you start with?
Picking up the coins, but I couldn't pick many up.
Dice?
Oh yeah, dice.
Yeah.
Basic things, basically.
Yeah.
The very basics.
Yeah.
Even just picking stuff up, like picking a cup up or pouring water from one cup to the other. And that
Was it very frustrating?
massively
When
frustrating.
your
But
arm still really...
you can feel yourself getting better, but you can see the improvements, if you know what I mean. So that's the goal, and the feedback is really important because you can see yourself getting better.
Yes.
So you're thinking, it might only be improved 10 seconds, but that's massive, if you know what I mean. Like 10 seconds for a normal person is probably nothing, but for you doing the course, it's huge.
Yeah.
Or even if you get one coin more every day, you're like, how good is this?
So did everything that you practiced measured in some way so that you always knew that you were changing?
Yeah, so how many pours I did that day, how many shelves I put the cup on, count how many shelves, right? 10, then 15 the next day, or 12 the next day, or whatever. I can't remember the numbers, but how many coins I could get in one hand, how many nuts and bolts I could do, everything was counted. And
So I saw you do this, and are you referring to the graph that
the graph,
you
that's
showed?
right.
Yeah.
Yeah.
So graphing of the results as well.
and you see the graph as well, so you can see you can see yourself heading on an upward scale, which is what you need.
So that really helped with your motivation.
Massively helps with your motivation, massively help. Well, I am anyway, because like I say, I could see the improvements in myself and I was getting better. So it was making me happy because I'm thinking the amount you got to put in to do the course is worth it. Look at the improvements I'm making.
And Scott, were there any times where you felt like you wanted to give up on the program at all, or anything that really frustrated you? Or
No, not really, because I could see the improvements.
you were driven the whole way.
Yeah, exactly, and you could see the improvement because you could, like, the graph going up. So
it's a good way
maybe
to
if it had a
motivate
platter or
yourself.
it going down, you think this isn't worth it, you know what I mean? But you get out what you put into it, if you know what I mean. So that's my big motto. You get out of life what you put into it. So if you're willing to put in the effort, you see the results.
The other thing is that what we do find though is that often it's around the halfway mark that people will start to find that things are really starting to get a bit tough going. It starts to feel like a little bit of a hard slog. And so what we implemented, very basic, but that at the midway mark, we would give people a certificate to say, congratulations, you made it halfway through your CIMT program, and tally up and give them a record of this is how many repetitions you've done, this is how many hours of practice, you've done really, really well. And for a lot of people that's been really motivating and helped them to kind of push through the final week. So
Yeah.
The other thing that has motivated some people is as part of the transfer package, doing a behaviour contract and signing the end of the page and saying, I'm going to commit to this for a 2-week period. A lot of people have found that really valuable in that, I've agreed to doing this, formally agreed, so I'm going to stick with it and I'm going to give it my best shot.
What have you done to make it easier for clinicians? Like, what is it about your package that makes it easier for clinicians to do it?
Yeah, I think some of the things that we've done is that we've created resources so that people have a preset manual that has all the templates of everything that you need to do the transfer package. There's templates for recording your shaping activities so that all people have to do is print that off and then you're ready to start. We also had some fabulous allied health assistants who actually also even took those templates a step further and pre-set up individual patient folders so that for each day of the CIMT program it has all the forms in order of what you need to do. So the homework records there, the home diary, your shaping sheets, everything's ready. So you just flip to the next page and then it's got the next step for you. And we think that was really helpful too in terms of implementing a joint model where it was physiotherapists and occupational therapists working together, that then you can see quite clearly where things are up to. It's easier to track and to then share the load. In terms of other strategies, I think that joint model can't be underestimated of us all working together to deliver programs. Definitely the ones that seem to be most successful is where that's been done very collaboratively. And also thinking about with CIMT, there's elements where it's really critical, the intensive practice, the MIT, the transfer package, that we're sticking to the fidelity of the intervention, but then thinking creatively about the bits where you can flex a little. So things like the functional task practice. Can you have multiple patients doing that component together in a kitchen where you divide up so they might all be working on one task but they have elements that they're doing of each together to reduce the supervision requirements?
The other thing was showing clinicians different types of models of implementation was really important so that services could find a model that suited them best. So looking at the 9 sites that Lauren's study, the Active Arm study was on, a lot of the sites had very different ways of implementing CIMT and found what worked best for them. So for example, where I work, as I said earlier, we implement a group-based program where we might have 3 participants at the same time. It's physio and OT together, pulling resources from the inpatient and the community team to be delivering the program. And we have a therapist schedule where you roster yourself on for shifts and implementing the program, and that works for our service. It might not necessarily work for other services. So other services will implement a one-on-one model. There's the 3-week model that Lauren had suggested as well. So finding what works best for your service as a team, and that's kind of the best way to implement OT and physio together. And it's important to share the load of not just implementing in terms of delivering the intervention, but also the organisational side of it, and getting everyone kind of on the same page to be able to implement the intervention.
I can think of 2 other things I think are probably important to mention. One thing is that one of the implementation strategies that we used within our study was a community of practice. So each team nominated a local champion. They dial into a teleconference. It was only a maximum 1-hour meeting once a month, but that was where each of the 9 teams would problem solve together. So someone would say, I'm facing this challenge, how have you overcome it? And that sharing of ideas across the district really helped people to be able to get it up and running. So every single one of those 9 teams delivered multiple CIMT programs in the study period, and a lot of them had never delivered any before. So we had no sites who didn't get it up and going, which was great. So I think that that's really important, working out how you can share and learn from others. I mean, this is a great forum to be able to do that. Another element of our implementation strategies was that we gave each of the teams every 3 months feedback on their performance. So how many people had come through their service that were eligible for, offered, and then delivered CIMT. And I think being able to share that information, and also if they had delivered programs, what had been the outcomes, was also very encouraging and motivating.
When you audited, the audit was largely looking at the inclusion criteria for it and checking that the therapists were applying the inclusion criteria routinely across all the patients and routinely offering it to anybody who met
the criteria.
Was the inclusion criteria the same as the Wolf study, or did you modify that?
People had some available finger, thumb and wrist movement. Were they then offered and delivered a CIMT program? And if they weren't eligible, we also noted the reasons why. So things like if it's documented that the person has a very severe cognitive impairment, then they're marked as ineligible. And we found within our study, we audited close to 1,600 files across those 9 teams, that it was generally about a third of stroke survivors were eligible for CIMT.
Yes, it's a large number.
And that's remembering, I guess, that we had a mix of acute, rehab and community services.
And how did the therapist compliance change over time?
Changed a lot, which was fabulous to see. So at our baseline, we had across those 9 teams, less than 2% of eligible people were being offered and delivered a CIMT program. We then remeasured that after delivering our implementation package, which included some of the training workshops, the community of practice, and we had improvements across each of the audit time points over an 18-month period. By the final evaluation, we had, it was 75% of eligible people were being offered CIMT, and then I think it was around 55% then were delivered a program. So if we're looking at that through an implementation science lens, where 10 to 15% practice change is considered good, we were very happy with the outcomes.
And I guess the impact for therapists of seeing people who've gone through the program and are so happy with the results must be enormous.
Yeah.
One of the things we struggled with was therapists thinking that it was a mean thing to do to somebody to put a restraint onto their intact arm. And I guess what they kind of need is to hear the experience of somebody like Scott, who, you know, when it's just has made an extraordinary difference.
Massive difference.
So,
I think that was discussed in the community of practice a fair bit, and it's important to remember, we did continue to say this, the MIT isn't a restraint, it's a reminder. So it's only there to remind the person not to use their stronger arm. So it's removable. So it's not a physical restraint.
If you want to cheat, you can. If you want to take it off and do whatever you want with it, you can.
And
just
you know, we just use
use
other mitts. It's not. It's not strapped onto the arm. You just take it off.
I think the other important point on that, Reem, which I think is really important to reinforce, is that's another really critical bit of why the behavioural contract is so important to establish before you start a CIMT program with someone, because having done a CIMT training with someone from the Talk Clinic, that was really reinforced. That behavioural contract helps you to outline as well MIT on and MIT off activities for safety. Safety should still be paramount, but that's why it's really important that you outline all of that and document it well before the person begins their program. There was one other thing I just wanted to mention around service delivery of CIMT, and it's more just, I guess, putting a challenge to the audience, is that I think it's also about challenging what we've thought of as traditional models of how we deliver our rehab. Because at the moment, we're all, resources are limited. We've only got a finite amount of resources. But I think it's also thinking about, well, I can do this intensive intervention with someone for a 2-week period. Am I likely to get or see better benefits than seeing them for our traditional once a week or once a fortnight as an outpatient for months and months on end? And really thinking about, well, if you added up your time, maybe it's just considering delivering your therapy in a different model, in a different way, and then getting better bang for your buck. And that's where I think as well, one of the other really critical supports for us was that we had really good support from the managers of occupational therapy and physiotherapy within our study across the district. So if you can get some buy-in and support from your management team, that can also be really helpful.
Do you envisage that your resources will be available for clinicians, and how's that all going to work?
Yes, we hope so. We've already made available some training videos which form a component of our implementation workshops that we run, are readily available on the South Western Sydney Local Health District YouTube website. We do hope in the future to make some of our written resources more available as well, but we're just still tying up the study at the moment. So.
And on the resources side of things, the Active Arm study did provide a lot of the paper resources, but it was really therapists that then took that and were really creative in how they implemented that. Things around creating kind of a grid board table, which you'd remember, Scott, so that it made things easier to record. So
in terms of
setting up a shaping activity and progressing it, so having letters on one end and numbers just like a battleship's board, and just writing those things down as to where the items are placed on the table, rather than measuring as in the protocol. Some other things are the physical resources, like the upper limb therapy equipment. We just had about $100, was it, that spent at kind of department store or cheap stores, and just bought daily household items, things like pegs and dominoes and cards and Lego, spray bottles and rulers, and just use those
coins.
things. Yeah, so a lot of very low cost items that were used to implement the program.
We also had one of the clinical teams, as part of a student project, developed a bank of shaping activities as well, to then use as a resource for future programs, so that people can use that as an easy way of progressing activities, again, to make it easier to implement in practice. And they've been very kind in sharing that resource when people request it.
Have they done many studies comparing CIMT compared to, say, usual rehab outpatient kind of treatment models? So in terms of the results between those two models of care?
Well, a lot of the randomised control trials compare CIMT to usual care. But then in addition to that, there was a study that was done in Canada, I hope I've remembered this correctly, by Ted Stevenson, where they actually compared CIMT to other upper limb interventions delivered at the same intensity. And they measured that in terms of number of minutes of active practice was used as the measure. Within that study, they found CIMT to be superior to dose-matched interventions. So that's another, I guess, important consideration if you're considering doing CIMT versus something else for someone who's eligible for it.
Reem, as a physio, what about competing priorities of getting enough practice of other tasks that you need to work on with your patients?
So we have a lot of group classes that run in our unit. We have one a day. In physio alone, and obviously other therapies also have group-based therapy. So we will try and continue to have the CIMT participant continue to go through those classes. And also it's important to consider the goals of the person. So if their goal is to work on their upper limb, then it's a negotiation of, if we work on your upper limb, that might be the focus for the next 2 weeks. You can still do physio outside of those times or as a home exercise program, but for 2 weeks we're going to focus on your arm, and it's about negotiating and prioritising with the patient as well.
Prior to doing CIMT, you worked quite a lot on some of your goals around your walking and movement.
Yeah, walking and movement, not so much on the arm.
So that brings up a really important point of the right therapy for the right patient
Person
at the right time. And we found that for a lot of our patients at the brain injury unit in particular, exactly what Scott had mentioned. I want to work on my walking, I want to walk, I want to walk, I want to walk. And then once his walking got to a certain level where he was okay with it, that's when he realised, I want to use my left hand now. So that's, the right time for Scott was when his walking was at a level that he was okay with to do the program. Yeah.
And what about when the 2 weeks finishes? What happens? Is there a program after?
So usually or with our sites, what we had recommended people do is in line with what's recommended by the TORB clinic in terms of the protocol they use. So it's really seeing the CIMT program as kind of a boot camp for the arm to kind of encourage use and generalisation into everyday life. So usually you will then, in that final session, set some ongoing goals with the individual, maybe set them some activities, but they're to continue working on those as part of their, I guess, as more of an independent program, with the idea that because it's been focused on behaviour change, it's really then about generalising what you've been working on for 2 weeks into using the arm in day-to-day life. What we found was that in terms of looking at the participant outcomes for the people within our study who received CIMT, is that post-program we then did some follow-up outcome measures 1 month afterwards, and people were making further improvements, quite significant improvements still, just in terms of generalising using their arm day to day.
Did you ever want to do it for longer than the 2 weeks, or were you happy with that?
No,
the 2
trust
weeks?
me, 2 weeks was plenty.
Yeah. And so at the end of the 2 weeks you were just spontaneously using
it. Yes. Then you start, you can use it in your head. You think, why stop now?
Yeah.
You've made all these improvements.
Yeah.
Why go back to where you used to be?
Yeah.
Keep it there.
I think the transfer package is really important in changing that that mindset of patients, like Scott's saying at the end, why wouldn't you use it? So, changing learned non-use into the very opposite of that. So, we found in particular the daily administration of the MAL is really important because, you might ask a question of, have you used your affected arm how much have you used your affected arm to use a remote control? And, participants thinking, I forgot to use my arm to use the remote control. I'm going to do that tonight. So it's, just really reinforcing.
Have there been many scenarios where you found that a patient have been doing their hours of practice, but they're just not improving?
With the EXCITE trial, there was also then a follow-up study where they looked at a delayed group who were, I think it's 21 to 24 months post-stroke. And they still made clinically important improvements, but not to quite the same level as the 3 to 9 month cohort. I think for us, if I'm putting my clinician hat on, if I'm not seeing improvements in someone's CIMT program, I'm then reflecting, what am I doing as a therapist? That would suggest that I've probably set tasks that are too hard, that don't actually meet their specific motor impairments. So I'd be going back to doing some really good observational task analysis, making sure I'm really clear on, exactly what are their specific motor impairments so that I'm making sure I'm targeting that as part of their program.
So for someone like myself who's just, quite new to the implementation of something like this, what are your 3 key pieces of advice?
Use resources that are readily available to increase your knowledge and skills. So things like, sound like I'm plugging advertising, but watching our YouTube videos, if that'll help you with upskilling. The Stroke Ed collaboration that Simone's a part of has a really good resource book as well to give you an idea of kind of what you need to cover as part of a CIMT program. So I think that that is really good to do. Looking for opportunities to shadow. So if that's either through, if you have a senior that you work with that's experienced in it, great. If they're not though, I mean, we've got a collaboration of clinicians across southwestern Sydney who are very happy to support others. So looking at opportunities to kind of tap into existing resources, go along, watch someone else do it to help you develop your own knowledge and skills. And working out how you can do it across disciplines as well.
Yeah, selling it maybe to other therapists in your area and physios and OTs, and then how you might implement that as a team.
Yeah.
Because it will certainly be too difficult as an individual that hasn't done it before to try and implement it on your own. I think it is very, very,
Very hard.
challenging. So if you can get other people together and work as a team, that definitely makes it much more achievable.
Okay. And it really draws on the strengths too of both disciplines in terms of the combination of the shaping activities and then the functional task practice, and then looking at how you apply that to, you know, the homework tasks are often focused on use of the arm in activities of daily living. So if you can draw on the strengths of both disciplines working together, then that works really nicely too.
I think I'd like to say thank you very much to everybody, and thank you, Scott, for sharing.
No problem.
For sharing your
Thank you for having me.
It's really valuable. Yes.